Hi. Hi.
Please start, ma'am.
Yes.
Deepa ma'am?
Yes, ma'am. Good evening, everyone. It gives me immense pleasure to welcome you all to this FOGSI ICOG CME on breastfeeding's best start in life, organized in association with Breast and Puerperal Health Committee, FOGSI. Now I invite the convener of today's CME, Dr. Niba Mohan Madam, who's chairperson of Breast and Puerperal Health Committee, FOGSI, to kindly welcome and introduce our dignitaries. Welcome you, ma'am. Let's start the session with the prayer to the goddess.
Will it go, Sangeeta? Nilima?
Nilima started.
Nilima? I think with saying a big Om.
Wait, ma'am. Yeah,
Okay,
network
okay.
issue. Just time.
Welcome, Dr. Niba, ma'am.
So, good evening, everyone. A very warm welcome to one and all who have joined in today's webinar, Breastfeeding Best Start in Life, jointly organized by FOGSI ICOG and Breast and Puerperal Health Committee, FOGSI. At the outset, I extend my gratitude to FOGSI President Dr. Bhaskar Palsar and ICOG Chair Dr. Sheila Mane Madam for this opportunity to Breast and Puerperal Health Committee year 2026. Thanks to Secretary General FOGSI Dr. Suvarna Khadelkar, Madam, Vice President ICOG Dr. Sadhna Gupta, and Secretary ICOG Dr. Pratik Tambe for all the guidance and support for today's webinar. And very quick response of dear Sir Dr. Pratik Tambe Sir to all my queries, as this is the first webinar of Breast and Puerperal Health Committee with ICOG. So recently we observed World Breastfeeding Week during 1st and 7th August with our online courses for importance of breastfeeding. And I'm happy to share that we had trained all more than 1,000 nursing staffs for this importance of breastfeeding, and this is in this continuity of to share the importance of breastfeeding. We all are aware about benefits of breastfeeding to mother and the baby, and know that it's not just nutrition for baby. The colostrum creates a protecting lining in the baby's sterile gut, and which blocks the harmful pathway, apart from providing immunity and protection for different diseases for the newborn baby. Just few important points to share, that the importance of golden hour in breastfeeding is not just because the early initiation for breastfeeding, because baby is most active within first hour with his reflexes, and that activity resumes after 2 to 3 days only. And another one is rule of three for working mother, which we must never forget to share with the working mothers, which they are really worried for. Then the how long breastfeeding should be done, about the recent of from the WHO that the exclusive breastfeeding is for 6 months, then it should be continued along with the solid food for another 2 years, as long as she is comfortable with. The only concern that we know the importance of breastfeeding, but the NFS data shows that the exclusive breastfeeding, which was more than 63% during 19 and 21, the current status shows that exclusive breastfeeding incidence has reduced to 58% in India. So we all are responsible to increase the exclusive breastfeeding and initial early breastfeeding for all the mothers. So with this thought, we start this webinar, and I welcome ICOG Chairperson Dr. Sheila Mane Madam, and can we have her CV, please? And as a chairperson,
we'll go ahead. Don't want
okay.
the CV.
Then we'll just like to have a few sentences from Dr.
remove
Sheila
my
Mane
CV.
Madam.
Let me come on the main screen. That is better.
Okay.
Yeah.
So few sentences from you, Madam, about that.
Yeah.
Yes.
You can highlight me on the screen. That will be better.
Yes. Please share Sheila Mane's.
Person who is speaking. Yeah. So good evening, everybody. And I'm really happy that Dr. Neva has accepted for this webinar. And as we couldn't do it during the breastfeeding promotion week, but we had an opportunity to having Madam Prabila Modi with us for the Guru Mantra. And Dr. Pratik said, at least we could do that activity with Madam in that feeding promotion week. So it is very important, Dr. Neva, as you told, and the percentage has come down, and it has come in today's paper also, Times of India, even in Bangalore, that it is coming down. So we know all the social reasons and everything we know. In fact, now it has been extended to 24 months. Okay, the recent guideline says that for 2 years also the mother can feed the baby. So we have to promote it more and more. Maybe the government will, and the employers will have to have some different leave pattern for the mothers then, or the facility when they bring the children to the working place to take care of them. I think then only it will be possible. The another thing which is happening is the milk bank. Now we have in Bangalore, we have two milk banks. One is in Bangalore Medical College, Vani Vilas Hospital, which is the largest hospital, and another one we have in Rainbow Hospital. Okay, so we have two milk banks, and I must tell you that I learned one rule of mantra, that is 3 from Madam Prabila Modi, that if at room temperature the breast milk can be stored for 3 hours, okay, in
Yes.
the refrigerator for 3 days, and in deep freezer for 3 months. So
Okay.
that has stuck in my mind, and most of the working women will have to understand that, because they can extract the breast milk and then they can go. So the baby is fed with breast milk only. And as you said, Dr. Mangalavani is here. We have learned from her that even if it is a cesarean section, you can immediately put the baby to breast. And that golden minute for that golden liquid or golden hour is very, very important. So we call it as a golden liquid. So you already told the importance of that golden liquid. So thank you very much. And I welcome all the faculty members, Mangalavani, Lakshmi, and then yourself, I think Dr. Sneha Buyar and Dr.
Dr. Pam.
Good evening,
yeah,
Madam.
they are going to, and all the,
Thank
yeah,
you. Thank you for
and everybody who is going to speak today, as well as all the chairpersons. So we have esteemed faculty today. Thank you very much for accepting, and wishing you all the best.
Thank you.
And welcome all my governing council members who are present here. Okay, Deepa, I can see Anita. I think Shashibala will be there, who always has
She's there.
Yeah,
She's
there.
speaker as well.
Shashibala, if I have to take attendance, Shashibala is the first. Taru Chaya, yes, thank you for joining. Deepika also very much there. So thank you all of you, and all the best. Okay, Neva, and thank you for doing this.
Thank you so much, Madam. Thank you. Now, may I request Secretary ICOG Dr. Pratik Tambe for his valuable words. I think Vice President Madam has not joined yet. will have her words in between when she joins.
So let me
So
begin by thanking Dr. Nibha Mohan, who is the chair for the Study in Female Breast
please share
Committee
his TV in
chairperson.
background, Dr.
Not
Neil.
required, that's fine. They're all known to each
No,
other.
it's okay. It's okay.
Let me also thank the coordinators for today, Dr. Deepa Gupta and Dr. Meeta Gupta, who are both our ICOG Governing Council members. As I remarked, breastfeeding promotion is one of the important activities of any OBGYN organization. As ICOG, this is something that we also need to actively promote. And though the breastfeeding week may have been over, I'm very happy that this activity has been arranged. Thank you very much, Dr. Neba, for gathering together a host of senior and eminent stalwarts in this field. And we also have Dr. Sneha Goyer, who is a past chairperson of the same committee, who is going to be conducting the panel a little while later. So thank you very much to all the esteemed faculty for sparing your valuable and precious time. And I must place on record the efforts of our ICOG backend team, Nilima as well as Poonam, for making sure that the flyer was ready in just 24 hours time, disseminating
Yes,
it to
commendable.
all 45,000 members. So thank you very much to our ICOG staff as well. Please proceed.
Thank you. Thank you so much, Dr. Pratik. So before we start the scientific session, I must welcome personally the speakers who just accepted within minutes of my request. Dr. Mangalavani, super lactation consultant, Dr. Lakshmi Shrikhande madam. She readily accepted to be a speaker. And I welcome Dr. Shobha Gudi also, Shobha Gudi madam. Is she here? Yes. Then
She's traveling, she's on the road. She joined
okay,
late.
okay.
I'm
And
here.
Dr.
I'm here. I came here.
Shashi
Yeah.
Bala Bhosle, welcome, Dr. Shobha. And as a chairperson, I welcome Dr. Sadhna Gupta, who's the vice president ICOG as well. Dr. Shobha, Dr. Supriya Jaswal, then Dr. Vidya Thobi, vice president FOGSI, Dr. Pragya Mishra Chaudhary, who was immediate secretary general of ISOPAR, and Dr. Amita Sinha. I welcome Dr. Abharani Sinha, Vice President FOGSI, Dr. Rosa Ulay, Madam. I'm really thankful to you, Madam, accepted within a minute of this this effort. Dr. Meena Saman, and as a panel moderator, I'm really thankful to Dr. Sneha Goyar, who was really busy within these days, and she accepted to moderate the panel. Dr. Taru Chaya as well, and Dr. Divya Singhal as an expert, and all the esteemed panelists, Dr. Anita Razoria, Dr. Meeta Gupta, Dr. Charu Modi, Dr. Deepa, Dr. Shilpa, and Dr. Lalita. Welcome you all, and let's start the scientific session. Over to Dr. Deepa.
Thank you, ma'am. Breastfeeding is perhaps one of the most natural acts of motherhood. But we all know natural does not always mean easy. So today's CMA is therefore not just about promoting breastfeeding. It is about learning how to make breastfeeding successful. So let's begin this enriching academic journey with the first topic, breastfeeding positioning and good attachment. It's my proud privilege to invite chairperson for the first session, Dr. Sadhna Gupta madam. Madam is a highly accomplished gynecologist from Gorakhpur, and ma'am is currently vice chairperson ICOG. We welcome you, ma'am. Dr. Shobha Gudi madam. Ma'am is vice president elect FOGSI South Zone, and ma'am is professor HOD St. Philomena's Hospital, Bangalore. We welcome you, ma'am. Dr. Supriya Jaiswal madam is vice president Patna Obs and Gynae Society, and she had been a chairperson Adolescent Health Committee FOGSI. We welcome you, ma'am. Now I request Dr. Shobha Gudi madam to kindly introduce our speaker, Dr. Mangalavani madam.
Yeah. Thank you so much, Deepa, and the organizers, and Sheila, Pratik, and Nibha for giving me this opportunity. It is indeed a privilege, and the privilege just now doubled because I have to introduce Dr. Mangalavani. In my mind, Mangla has been the foremost, proponent of breastfeeding, and she has been the ground level soldier for this cause with extreme honor and privilege, I introduce her. She's the director of Hirkani Gynecology and Breastfeeding Medicine Center, Pune, and past president of the Breastfeeding Promotion Network of India, BPNL, in 2015 to 23, a really long tenure and must have been very, very highly productive tenure. Executive Vice President of POGS also. And I think the first practicing IBCLC in India, founder, convener of annual breastfeeding conference, and the founder course director of IBCLC lactation training, BPNL. I welcome you, Dr. Mangla. I think
Thank
they could
you.
not have chosen a better
I think that
speaker than you. Thank you. Thank you
Thank
so
you
much.
so much for the kind introduction, Shobhaji. First of all, I must thank you, ICOG and FOGSI together arranging this beautiful program, and congratulations to all. And Dr. Sheila Mane, Madam, the chairperson, ICOG, Dr. Sadhna Gupta, Dr. Pratik Tambe sir, and Nibha Mohan. Thank you so much for inviting me for such a beautiful platform. And thank you, Shobha Madam, for the introduction. So let me first share my presentation. Right. Can you see my slides?
Not yet, ma'am.
No, ma'am.
Not yet. Okay. Can you see now?
Yes, ma'am.
Yes, it's seen.
Yes, thank you. So, good evening again. So, let us start with this beautiful program on breastfeeding, and I'm going to talk mainly on the position and the latching of the baby. So, we all know that breastfeeding is the physiological norm. So, all the animals who breastfeed, who have a breast, they are called as the mammals. You know, and it is not something new. It is going for years. It is in our culture, and we know now the benefits are so well. But if you see globally, 2 out of 3 babies are either artificial fed or fed on the mixture of both, and the formula business is valued as 88 billion worldwide. So you can see this figure. Like 8 years ago, when I presented my lecture, it was 14 billions. And then slowly it has increased the number, and now it is 88 billions. So I wonder, what we are doing, why we are not able to stop this formula business with such a high intensity. There are so many reasons behind that. So hopefully we will cover most of them in these 3 hours. And nearly every mother initiates breastfeeding. But why more than 50% of the mothers not able to continue? And there are so many reasons. And main is the difficulty with the technique. And that is why I have taken this talk. So baby not satisfied. There are so many breastfeeding problems, which Sneha is going to cover later on. So I will not talk about that. So mother complain, but they are actually a falsies, that my baby is premature, or my baby prefers the bottle, I don't have enough milk, my breasts are too small or too big, I got a fever, different. But we can actually cross all those barriers and continue the breastfeeding. When the mother cannot breastfeed, she has this all combination of emotions in her whole life. First she gets anxious and sad, angry, and then she has this regret. She feels regret whole life. And not only the physical health, coming to the benefits, the higher risk of postpartum depression, for the women who intended to breastfeed, but they were unable to breastfeed. And there are two main hormones, the prolactin and the oxytocin, which are important for success of the breastfeeding. And those myoepithelial cells, there are fibers around, and when they contract they are around the alveoli, then only the milk is pushed into the ducts. So it is all hormonal play. It is not simply pressing the breast and the milk comes out. So most of the breastfeeding problems, if you see, they are caused by poor attachment of the baby to the breast. So it is vital to learn how to feed the baby with correct positioning and attachment. Now, if you see the other animals, you don't see they have a difficulty. We have never seen donkey going to the monkey and says, please, will you help my baby to latch, please? So why? Because they are unmedicated birth, and there is no mother and infant separation like we have in our hospitals. And there is an intact culture of the breastfeeding. Of course, recently zoo and circus animals, they do have difficulty because we are interfering all the natural processes. So contrary to belief, attaching the baby on the breast is not an ability which the mother is born. Rather, it is a learned skill which she must acquire. So basically, it is the skill that she has to learn. And we as a health professionals, we have important responsibility to make sure that mother learns that skill. So we have to have those skills first. Now, if you see how many mothers ever saw baby being breastfed. So if we see something, particularly from childhood, there is a higher possibility that we do it. So if you see the Facebook poll, 50% mothers said they never saw baby being breastfed. Not as a kid, not in the normal day, not even on the television. So why I have put the picture of the gorilla here? So there is a story in US, it happened because in the zoo animal, the baby was separated and given the milk by the bottle. So this gorilla never breastfed, but after couple of weeks they tried to put the baby near her. She refused to breastfeed. So ultimately, the local villager women, they came with their babies and they sat in front of her and breastfed. Looking at that, then she realized, and this gorilla started breastfeeding her baby. So it is important, nowadays with the nuclear families. So we have to make positive efforts about the breastfeeding culture. So the good common components of the latch, it is access to the breast of the baby. Make sure the baby is stable and there is a good contact between mother and the baby. And it is a large asymmetrical latch. So let us see what it is. So the attachment, or we call it as also pucker, how baby is attached or latched to the breast. So again, the baby has to have a maximum areola in the baby in her mouth. So why we don't say whole areola? Because the mother's breast, the size shapes, they differ. The size of the areola also differs. So it may not fit the whole areola in baby's mouth. So as much as it possible. For that, baby has to do the mouth wide open, then the lower lip is turned outwards, and the chin, baby chin is hugging the breast. So why we say that the mouth open? Because the new science, what it says, the ducts branch closer to the nipple. And the conventionally described lactiferous sinuses actually do not exist. So these are all the ducts. When the milk goes there, they dilate little bit. Glandular tissue is found very close to the nipple. And subcutaneous fat is very minimal at the base of the nipple. That is why if there is a deep latch, the success of the transfer of the milk from the mother to the baby is higher. So that is again the reason to accommodate whole the areola. the baby's mouth has to be wide. So when we give the training, these are the kind of figures we show to our delegates. And you can see on the left side, the maximum areola in baby's mouth and the chin touching the breast. As opposed here on the right side, baby's holding the nipple. And there where the problem starts and the breastfeeding falls down. So with that holding only the nipple, there is no adequate transfer of the milk, and also mother gets the nipple trauma. And then it is very, very painful. And the mother again tries to put again the baby little more further away. And it is more shallow latch. And then she actually ends up stopping the breastfeeding if she does not get any proper support, appropriate support. So again, this picture says the same thing. So this is the baby's attachment, the latching position. But now how the baby's position? So if you take as a whole baby, so this is the baby. Say hello to everybody. So actually the baby should be completely turned towards the mother. So there is a good skin to skin contact. So to have a good skin to skin contact, the baby should not be wrapped with the clothes, just the halka sa cotton kurta. And then the mother also should have a close front open. So nowadays in the market, you get this chain wale gowns and all. They are no good because breastfeeding is not like a bottle feeding. So like our previous dress, sari and the blouse is extremely good for breastfeeding, but we also nowadays don't wear much sari, but any front open clothes is good enough. And head and body in one line of the baby. And the baby is well supported, the neck, back, and the buttocks. Because if the baby is not well supported, she's always afraid that, for a fear of falling down and not able to concentrate. Again, the mother has to be comfortable and elbow support with the lot of pillows around and the knee level with the hips so that her thighs are straight and the baby doesn't tend to go away from the mother. Again, I said front open close, mother relaxed, lot of oxytocin and prolactin she needs, and holding C-shaped and bringing baby to the breast rather than she bending and putting the breast to the baby. So if you see the traditional, the women, they hold the breast like a scissor hold, just with the two finger. With that, the deep latch is not possible. So it is not advisable. So it is like C hold or the U hold, depending on how the baby's position. So how we eat the sandwich, like that, if we press the breast little bit, but behind the areola, not very closer, it is easier. So it just says when the baby does then just touching the upper lip or the tip of the nose, then baby opens the mouth and then the putting the baby to the breast. There's something called breast crawl. I think in the initiation next lecture, Lakshmi madam is going to mention about this. So we will come to maternal positions. So there are 4 main maternal positions, but I think there are many. But to learn, to teach the skill to the mother, we can tell those and see in what position she's comfortable. It is important even during antenatal period, we discuss all this. At least good 1 hour or 2 hours separate antenatal class just on breastfeeding. So cradle hold is when she's taking the baby on the left breast, then she supports the baby with the left hand only. So on the elbow, the baby's head is resting. In the cross cradle, it is if the left breast with the right hand, she supports the baby. But she supports the baby at the nape of the neck here. That is the weakest part. We never push the head of the baby. We just hold here. Why we don't push the head? If we push the head, what happens? Our neck becomes flexed. And when we are drinking water, we don't drink like that. Our neck is extended. So similarly, baby's neck has to be extended. So we don't press on the head, we just hold here. So that is what the cross cradle. Then the football is the similar like cross cradle, but it is the same side, so that if there are twins, she can hold two babies together. There are large breast or pendulous breast. In those conditions also, this is good position. And sideline means mother lying down. I'm not saying sleeping, lying down, but mother is awake. She can feed the baby. Now, there is another position, laid back. The Christina Smiley from Australia has advocated this. This is when the mother is semi reclined and the baby is like that. So if there is a difficult latching, because there is a gravity, the baby falls on the breast. So it is automatically becomes the deep latch. So if there are difficulties or in the beginning, even for breast crawl, we give this position. So if you say the which one is the right position, of course we know it is written here also. The left one, why it is correct? Because you see the baby is completely turned towards the mother, and mother where she's looking, she's concentrating at the baby. Maybe she's talking to the baby, she's singing the song. And if you see the other one, baby just lying flat, and then the kind of she has just introduced the breast as if the bottle feeding, and then she's not even looking at the baby, she's watching the TV or maybe arguing with the partner, whatever it is. So that is those small things we have to explain to her. This is also again typical in Indian scenario we see. So we can just, if we have a little information, we can just correct the position so that we improve the effective milk transfer from mother to baby. So this is like a bottle feeding with the breast, so that has to be avoided. Another few things, nipples do not need to be cleaned before the feed. We have to teach mothers how to unlatch. So what we do, if she's taking the baby, when the baby is holding quickly the nipple areola complex, she should not just pull the baby. Then what happens? Nipple trauma. So she can put the little finger in the baby's corner in the mouth so that the gums remain open, and then she can withdraw. So no need to press the breast near the baby's nose, because another is worry is the nose is pressed, and then there are so many myths or baby is not able to breathe, but that is not true. Even if we touch, we can see we can still able to breathe. So as long as baby is sucking regularly, miss baby is breathing all right. So we don't have to worry, because if we press, what happens? The areola again comes out from the baby's mouth. So the latch may become superficial. If the baby is crying, we have to calm the baby first. We have to recognize the early hunger cues. And of course, assess positioning and latching multiple times. This is very important. Just one visit by lactation consultant is not enough. So we have to assess her multiple times and see whether she herself is confident holding the baby. So rules, and so these are so many regulations. Like when we are learning the car, you can see, you can remember in the beginning, the teacher tells so many things. Look at the mirror, the accelerator, the brake, the rear mirror, and then the car stops, again starts. But then after some time, we are even talking the phone and reach the destination. So it is similar. It is only in the beginning we have to see all those rules. Afterwards, I think wo beautifully chalega. So as a toddler, you can see any position. Another thing is if the baby is breastfeeding and you can see the baby's weight, stool, urine, everything is okay, we should not really tell her about correcting the position, because whatever is happening, the baby is gaining the weight. So we can just leave them alone like that. So they both have to be comfortable, no nipple trauma, and facilitate the milk transfer. Rate of milk synthesis is associated with the thoroughness of milk removal. So more the breast is emptied, more milk is prepared. Another thing, mother should breastfeed on the first breast first until the infant seems satisfied. That means the breast is empty before offering second breast. So It is not to give one breast or two breast. It is give one breast first. Many times the baby is full, then that's fine. You offer the another breast next time. But if baby is still hungry, then yes, you can offer the second breast also. So it again says that drained breast makes milk faster and the full breast makes milk slower. So if we miss the frequency, there is a longer period between the two breastfeeding, actually the milk can the preparation of the milk production can slow down, and she can, if and it is happening regularly, then her milk supply can low and low. So as we said earlier, how do we know there is enough milk transfer? That you can see the rhythmic swallow, suck, and breathe pattern, audible swallowing, relax. Baby's arms actually becomes relaxed. Initially, when baby is hungry, they are fist like that. So at the end, you see they are open. Moist, moist mouth, cheeks full, and the mother, the breast soften, she's relaxed. She may become thirsty, uterine contractions, and she may feel pain. There may be milk leaking from the opposite breast, and the nipples are elongated, but they are not pinched or abraded. And it is the demand feeding, and it is not like, on time. So there are so many factors influencing successful latch. So there are maternal factors going from anatomy, labor experience, knowledge, infant, again the anatomy, the gestational age, the labor experiences. Oh, what is that? My time. Okay. So sometimes we see like that. So again, we should not introduce the nipple. So we all should know what is enough milk. And when we give the formula, ultimately what happens, the mother's milk goes down. So we have to see the simple estimations looking at the baby's urine in hospital initial few days, when we are just doing the round, whether a baby has passed urine, how many times. Baby must pass stools 3 to 4 times every day first month. And if the baby has not passed stools, that means the baby has not enough intake. So simple things, baby does lose 7 to 8% of the weight in first week, but then the baby starts gaining. So regular follow up even after going home is extremely important. So comfort sucking and formation of nipple preference are genetically determined behaviors for imprinting on the mother's nipple. So whatever we put in baby's mouth in the beginning, that happens imprinting on the baby. And then we say the baby is not latching, but because we have disturbed the breastfeeding cycle. So providing women with extra organized support helps them breastfeed their babies for longer. Breastfeeding support may be more helpful if it is practicable, scheduled, and includes ongoing visits with trained health professionals. And believe me, we all needs to have some basic training so that we can see the hospital policies, whether we can change. We can also see how the breastfeeding going on generally. And if we have the guideline for supplementation, it is always mother's milk first, either direct breastfeeding or express milk, donor human milk, and then comes the formula. If you see this picture, the middle picture, the baby is separated. It is in the cradle. And then the two pictures on the side, the babies are with the mom. So where will the breastfeeding going to be successful? Of course, where there is a skin to skin contact. So when baby is separated, there is a more risk. Thank you so much.
May I request our chairpersons for their expert inputs? Supriya ma'am, Shobha ma'am.
Yeah. So first of all, thank you very
Can
much,
we
Dr.
take the questions?
Dr. Nibha Mohan. I really thank you for giving me this opportunity. And ICOG Chair, Dr. Sheila Mane ma'am, and Dr. Pratik Tambe sir, and Bhaskar sir, and everybody present here. It is a privilege for me to chair this session. And wonderful, excellent talk by Dr. Manglavani. You spoke so well, and really the position of the child, how the baby latches to the mother's breast is the most important thing, so that the baby can properly suck in the breast milk. So the position, this is a very, very important topic actually, because every house faces this, everybody has to learn about this, and we as healthcare professionals, we need to know everything about it, and you have explained so well. And about the Q&A, if anybody has any question.
Yeah. Thank you,
There's a
Mangla, for
question
that.
there.
Yeah. Can I say
uh,
something? One small comment.
yes, madam.
Yeah, yeah.
No,
So,
you please carry on.
yeah, that was a very wonderful deliberation, and I expected nothing
Yes.
less from Mangla, because I have
Mm.
seen her work for this cause. And she may think that, nobody is noticing her because she's not a FOGSI chair and all. But in fact, FOGSI has that eye for every good worker. And all of us chairpersons, we like to hone their skills. So, one thing, Mangla, very, very nicely put, that the urine output is important. And when I go for rounds, in addition to ensuring the latching position, as you so beautifully described, I also tell them not to use the Huggies, the Pampers. I tell them to make langots, the age-old traditional way of
Yes.
India, because I think Indian values for looking after the mother and neonate has lot of science in that. Every household has their, every community has their own culture about this, and in that, one of them is that you don't really dress up the baby too much. So
Mm.
I encourage them to have this milk cloth, 25 to 50 langots, and I ask them to change and make sure that at least 7 or 8 times it is changed in 24 hours, because it is soaked. Because if they use Huggies, you will not know how much. So that is very, very important. So thank you for bringing that out. And I think over to the.
Thank you, Dr. Manglamani ma'am, for your insightful session. Now moving over to the second session, antenatal counseling and the first golden hour. And the speaker for this talk is Dr. Lakshmi Shrikande madam. I called upon the chairpersons for this session. First, I will call Dr. Rosa Olai for this session. Vidya ma'am will be joining in the third session. Dr. Rosa Olai madam is Director, Olai Hospital, and she's State Coordinator for FOGSI Aduna project. We welcome you, ma'am. Dr. Pragya Mishra madam is currently, can I have the CV of Dr. Pragya ma'am? Yeah, ma'am is Consultant Infertility Specialist at New Life Test Tube Baby Center, NGM Hospital and Research Center. And ma'am has been President Patna Obs and Gynae Society in the past. We welcome you, ma'am. Our third chairperson is Dr. Amita Sinha. Thank you so much, ma'am. Dr. Amita Sinha, ma'am, is a consultant gynecologist in Patna, Secretary Patna Obs and Gynae Society, and Vice President Patna Obs and Gynae Society in the past. We welcome you, ma'am. Now I request Dr. Rosa, madam, to introduce Dr. Lakshmi Shrikande, ma'am.
Thank you so much, Deepa. You brought me to the second session. So, first of all, congratulations, Dr. Neva Mohan, the chairperson of the committee, for bringing up together such a good event that you've made with all your team. And of course, ICOG has brought up Dr. Sheila and, of course, my dear Pratik, who are doing excellent work. Neva, this is such an important topic that you've touched. And I'm so happy you brought up good speakers to your event. And one such whom I'm chairing is none other than my very good friend, Dr. Lakshmi Shrikande. Of course, we all know her. She's been where all Lakshmi you have not been. I don't know what to read, what to delete.
Don't read anything.
But I must say, as a friend, we've been together right from the time we were chairpersons in committee of FOGSI, and I've seen you grow to greater heights from ICOG to SAFOG, EOFOG, everywhere I've seen you. And I'm so happy to be chairing your session here, and I think we would like to hear from you. Such an important topic. Who else better than you can do justice to it? So, Lakshmi, over to you for the counseling and the first important hour. And I think we can then have discussions after your talk. Over to you, please.
Thank you, Roja. Seeing you after a long time, and it's really a pleasure to see you and interact with you. And Nibha, you are going great guns. And after Mangala Vani, I mean, she has really made my job very, very easy. The topic given to me by Nibha is antenatal counseling and the golden hour. But first, I just want to highlight why we gynecologists always care so much about the breastfeeding. We have breastfeeding week and so many webinars on breastfeeding. Because breastfeeding is not merely infant nutrition, it has got so many maternal and neonatal benefits. And when it comes to maternal benefits, it reduces postpartum hemorrhage, breast cancer, ovarian cancer, type 2 diabetes, hypertension, cardiovascular disease, and osteoporosis. And look at the infant benefits. There are lower neonatal mortality, less sepsis, less NEC, less pneumonia, less diarrhea, better IQ, reduced obesity, and reduced allergy. And the looking at the benefits, no doubt that we all gynecologists are talking and giving so much importance to the breastfeeding. But when it comes to exclusive breastfeeding, even the WHO targets are not fulfilled because many women they don't prefer to do exclusive breastfeeding. And the current concerns of we all OBGYNs are rising cesarean rates, delayed initiation of breastfeeding, early initiation of formula feeds, poor antenatal counseling, social media misinformation, and their return to work, early return to work. So, we obstetrician can influence almost all these factors. So remember, breastfeeding success starts during pregnancy and not after the pregnancy. Because when she is pregnant, many mothers they then only decide I will breastfeed or I will use formula food after my delivery is over. Hence, we have to start counseling in the antenatal period itself because evidence shows that antenatal counseling increases the chances for exclusive breastfeeding, it improves her confidence in exclusive breastfeeding, and it decreases the chances of early cessation, that is, she will go and feed for longer duration of time. So every antenatal visit is an opportunity for we to encourage her for breastfeeding. In the first visit, we can assess her knowledge. Second trimester, we can address the myths because nowadays with the social media, it is very, very common that they are misinformed rather than informed. And third trimester, we can teach them the correct positioning. We can discuss the golden hour with them and not only her, but we can prepare husband and family for the exclusive breastfeeding. So, what we have to explain to her in the antenatal period? We have to explain why breast milk is unique. What are the advantages over formula feed? What is the importance of colostrum? The demand and supply principle, because many of them they suffer from breast engorgement and they are not able to figure it out what is happening, and out of frustration and pain many of these mothers they start resorting to the formula feed. We can explain that she has to do exclusive breastfeeding for 6 months and she has to continue breastfeeding for 2 years and beyond, of course, with complementary feeding. So, what are the common myths which we have to address during antenatal period? Definitely, first and foremost, my milk will not be enough. It will be less for the baby. Formula is stronger. Colostrum is dirty. Caesarean mothers cannot breastfeed. My breasts are too small. I am having flat nipples. I need special foods for breastfeeding. I am a working woman. So, how can I cope up with the breastfeeding demands? And also, breastfeeding will affect my body and breast shape. So, you can see the list of myths and concerns which she is having and which we have to address during the antenatal period. We also have to identify the mothers who are at high risk for breastfeeding problems. That is, if she gives you history of previous breastfeeding failure, she is a case of PCOS, obesity, diabetes, having thyroid problems. She had undergone breast surgery. She is having twins, preterm birth, IVF pregnancy, maternal depression, previous PPH, and of course, if she is having flat or inverted nipples. So, in the antenatal period, we should have to make it a habit to check the breast, and we have to identify the breast hypoplasia, previous surgery, really inverted nipples are there, how inverted they are, whether she has undergone any surgery, radiation, and are there any skin lesions over the breast. Then we also have to teach them the importance of colostrum, that this is the first vaccine rich in IgA, leukocytes, growth factors, stem cells, and oligosaccharides. And this is perfect for the newborn stomach. She can also go for antenatal colostrum harvesting, but this is not for each and every woman. The current evidence says that this is useful in selected mothers, especially if she is diabetic, when there is a high risk of neonatal hypoglycemia, or when there is a planned cesarean delivery. Usually harvesting is started at 36 to 37 weeks, but avoid if you feel that she is having a risk of preterm labor. So what is this antenatal colostrum harvesting? This is also known as antenatal milk expression. This is the hand expression of small amounts of colostrum during the last weeks of pregnancy, which is collected, stored, and frozen for use after birth if needed. It is not recommended as a routine practice for all pregnant women. It should be considered only in carefully selected women after individualized counseling. So, who are the women who will benefit from this harvesting? Diabetes mellitus patients, planned cesarean section with anticipated delayed breastfeeding, previous breastfeeding difficulties due to delayed lactogenesis, breast hypoplasia where there is a concern for milk production, multiple pregnancy, and previous infant requiring treatment for neonatal hypoglycemia. So, babies expected to be at risk of hypoglycemia are the infants of diabetic mothers, large for gestational age infant, and small for gestational age infant if delivery is near term. Who should not go for this harvesting? It should be avoided in those women who are having threatened preterm labor, previous spontaneous preterm birth with current risk, short cervix, placenta previa, antepartum hemorrhage, preterm premature rupture of membranes, cervical cerclage in situ, and any obstetric condition where nipple stimulation may theoretically increase the risk of labor. It should be started at 36 to 37 weeks, definitely not before 36 weeks, because nipple stimulation may increase endogenous oxytocin release, although evidence that it induces labor in low risk pregnancies is limited. How frequently it should be done? Usually once or twice daily, 5 to 10 minutes per breast. Stop if she feels any contraction, and it should be freezed immediately at minus 18 degrees centigrade or below. This is the evidence, that is the DAME trial, diabetes and antenatal milk expressing trial, which was a multi-center randomized control trial involving women with diabetes in pregnancy, and they found that ACH from 36 weeks did not increase NICU admissions. It did not increase preterm birth when performed in women at low obstetric risk. It increased the availability of mother's own colostrum after birth. It supported breastfeeding without significant adverse maternal or neonatal outcomes, and it appears safe in low-risk women with diabetes when started after 36 weeks under appropriate supervision. So these are the plans for successful breastfeeding, which we have to discuss before delivery in the antenatal period itself, that we have to explain them about the immediate skin-to-skin contact after birth. There should not be any unnecessary separation. Many places, they just separate the baby to another room. Rooming in should be encouraged. No prelactial feed should be given. You have to delay the bathing. Immediately the sisters, they take over the child to give the child a bath, and the support person from the family should always be involved for successful breastfeeding. What is this golden hour? It is the first hour after birth. The baby is alert, awake, ready to suck with highest oxytocin response, and this hour predicts the long-term breastfeeding success. We have to encourage the breast crawl. The healthy newborn can crawl, locate nipple, self-attach, and initiate breastfeeding immediately. There are various benefits of immediate skin-to-skin contact, as it improves the temperature, gives better glucose control, better oxygenation, less crying, better bonding, earlier breastfeeding, and higher exclusive breastfeeding rates are seen with skin-to-skin contact. What about delayed cord clamping and breastfeeding? Delayed cord clamping improves the neonatal iron stores, but it does not delay the breastfeeding, and both practices should coexist. That is, before cord clamping, you can allow baby skin to skin contact and you can allow baby crawl. What about cesarean birth? Baby can start breastfeeding within 1 hour. Yes, in the cases of cesarean delivery as well, because we all are using regional anesthesia in most of the cases. As soon as the baby is born, even by cesarean section, you can put the baby on the mother's abdomen, let baby crawl, find out the nipple and start sucking. Partner support is very, very important, and you have to avoid the unnecessary separation of baby from the mother. There are certain labor room practices that really harms the breastfeeding. That is routine nursery admissions. Most of the sisters, they immediately start call for the formula feed, and they feel that the child will not suck, and they immediately give the first feed as the formula feed. They delay the skin to skin contact. You allow the frequent visitors to visit this newborn mother, this newly delivered mother. Bottle feeding should be thoroughly discouraged. Don't give glucose water and pacifiers. Baby friendly hospital initiative is there, and we all have to encourage. The key practices in this initiative is that there are written breastfeeding policies in these hospitals. Staff is well trained in breastfeeding practices. They start early initiation. They encourage for exclusive breastfeeding. Rooming in is allowed, though unnecessary supplements are given, and even after discharge, the mother is provided for the support as far as breastfeeding is concerned. We obstetricians are in a position to decide our own labor room practices. We decide our cesarean protocols. We can counsel the husband and family for breastfeeding. We decide the hospital policies and the discharge advice. So you can see that as an obstetrician, your influence begins before birth, not after it, and your influence determines the successful breastfeeding after the birth of the baby. So the key take home message is that breastfeeding success starts during pregnancy. Every antenatal visit is an opportunity for counseling. The golden hour is a critical window for successful lactation. Skin to skin contact and early initiation should be routine after both vaginal and cesarean births, and obstetricians, they play a pivotal role in improving exclusive breastfeeding rates through evidence-based maternity care. Thank you, friends. Thank you so much for your patient care, for your patient listening.
Thank you, Lakshmi. Excellent, crisp, to the point. And I must say that what you just said is so very important. And I think once a patient comes to us, even from the 5th month of pregnancy, we must be very careful, counsel her with nipple care. I'm sure all of us must be doing, but that is so very important so that the nipples become a little hard during breastfeeding. They don't have that cut, which is there. Of course, what we can do nowadays with the rise of breast cancer, one of the best ways to prevent, not maybe BRCA1, BRCA2 is, something aside, but this is one thing that we can emphasize during our antenatal care. So thank you so much, Lakshmi, and I would like the other chairperson.
Pragya. Yes, Pragya ma'am.
Yeah, I'm there.
Hi, Pragya.
Yeah, it was, first of all, I would like to thank the ICOG chair, Dr. Sheila Mane, secretary and vice chair, Dr. Sadhana Gupta, and Pratik Tambe, the secretary, and of course, the convener for this program, Dr. Nibha Mohan, and the two coordinators, Deepa Gupta and Meeta Gupta, who were really at the helm of affairs that I should join on time, and which I did. And it's such a pleasure, to listen to Dr. Lakshmi Shrikande. I cannot fail to mention that, whatever aspect one listens to you on, your academic content is so good. I mean,
Thank
whether
you.
it's related to infertility or it's related to breastfeeding or to diabetes in pregnancy, whenever I've heard your lectures, they've always been fantastic. And today, I mean, I've actually learned a few new things about breastfeeding. Like, you know, you spoke about this antenatal colostrum collection, when to do, when not to do. Of course, you know, when there's a threat for preterm labor, avoid it. And so it was, and the key messages that, in fact, even the first lecture was brilliant, you know, it was quite good. So I just have a very small question to you that sometimes, you know, at about 22, 23 weeks, women come in with in pregnancy with galactoria. So how do you counsel these women? Because I just had one patient yesterday who called from home. She's about 23 weeks and she's having milk production at this stage. So what would you do and how would you counsel her?
You're asking me or Mangala? Mangala?
No, no, I'm asking you. I'm asking you because I
Acha.
was told to chair your session.
Because it depends, Pragya, how far, I mean, how much is the milk production? If it is just 1 or 2 drops, and so we really ignore, because we don't encourage the manual milk expression at 32 weeks of pregnancy. Because even the antenatal colostrum harvesting has to be started after the 36 weeks of pregnancy.
No, but this is more. This is more than a few drops. That's why she's worried and she's called from home. She stays in a peripheral area of Bihar, but she's under my care. So anyway, I've called her, but I'm just asking because obviously you can't do serum prolactin in pregnancy.
Yes.
So I just...
Yes, I understand.
Pragya, can I say a few words?
Can I add?
Next topic is no lactation, poor lactation. So the...
I think I
Pragya,
can add
you are mute.
that. Yeah, Pragya
Pragya,
ma'am.
you are mute. Unmute yourself, Pragya.
Pragya ma'am, yes.
They unmuted me. Actually, they muted me from the other end. I didn't mute myself.
No, your question is very, very practical, and many of our patients, they really have milk production at 32 weeks onwards, and we cannot do prolactin.
You have to counsel them, ma'am, that
She's
it
just
should
23
be,
weeks, Dr. Anika.
it should
She's
be
just 23 weeks. But
so
once
nothing alarming is there, ma'am. You have to just tell her that, okay, you need to be more careful because previously it was a teaching that it may suggest a failing placenta, but it doesn't hold true anymore. You have to just tell her, counsel her that she should wear a tight breast support and she has to avoid repeated nipple stimulation and she should not squeeze it out. If she will squeeze it out, there will be more let down. So you have to just counsel.
Ma'am, we
And you
need
have
to start the third
very,
session
very
on time.
important.
May I request
Preterm.
Dr. Amita ma'am to
Yes.
just say a few lines and then...
Let me finish. You
Thank
have
you,
to
Dr.
just
Deepa.
be cautious that patient doesn't land up in preterm labor.
Yeah. No, just quick one comment. Actually, 99% of the times, you know, I know it's harmless because I've had patients like that. But I just because these days, you know, we want to be over cautious. So I just asked, I asked the patient whether she's having any headaches and all that. I mean, do we need to exclude any pituitary tumors, adenomas, if someone is...
Yes.
That was my concern.
Yes, thank you, Lakshmi Madam, for your very insightful and clinically relevant presentation on antenatal counseling and the first golden hour. In my opinion, this golden hour, first golden hour, is a continuum that actually begins much before birth, that is during antenatal period, what you have emphasized on antenatal counseling. But in reality, those 60 minutes are often determined by the preparation that we take place during the preceding 9 months. Yes, madam. So I think antenatal counseling is not just simply giving information, but it is preparing the mother, preparing the family, preparing the health system, and ultimately preparing for that one critical hour when every minute matters. This golden hour, what we have learned in previous sessions and previous breastfeeding weeks, that it is about creating the right environment.
Yes, support system is also important. Yes.
And the first hour gives us a unique opportunity. This 60 minutes is important, very important for mother and child both. But this first hour gives us a unique opportunity to give the baby its first vaccine, not an injection. This is mother's cholesterol. So thank you, madam. Thank you so much for your brilliant presentation.
Thank you, respected seniors, for sharing your experience. Now, I request Dr. Meeta Gupta. I welcome her to carry on with the next session. Thank you so much.
Deepa, with this, that we have completed the first two sessions, so informative, beautifully explained by the speakers. We have come to the third session, and I have the honor of inviting the chairpersons for this session.
Hello.
Please.
Haji Nilakshi, boliye. हाँ.
Lakshmi ma'am, Lakshmi ma'am,
I have given your number to them.
हाँ, मुझे भी उनका दे दो.
Meeta, can you see my screen?
Ma'am, I
Yes,
can,
yes.
but ma'am, I wanted the
all
CVs.
to kindly mute themselves.
Ma'am, can we have the CV first? Shashi ma'am, आप एक minute रुक जाइए. Because we want to have the CV of the chairpersons.
Sure.
Please. Thank you so much, ma'am. Abharani Sinha ma'am is Vidya ma'am has already yes, thank you so much. It is an honor to welcome the first chairperson, Abharani Sinha ma'am. Ma'am is a principal, SKMC College, Muzaffarnagar. She is the Vice President 2026 FOGSI, Professor Obs and Gynae as SKMC Muzaffar. She has so many, credentials at her. As we are already running short of time, I will just go to the second chairperson. And Vidya Topi ma'am is the second chairperson. Se pehle wala Shreya. Thank you. Ma'am is the Vice President FOGSI 2026 as well as was the President of Kasoga 2023. Ma'am was Chairperson Food, Drugs and Medical Surgical Equipment Committee FOGSI 18 to 2020. Ma'am, it's an honor to welcome you as a chairperson for this session. The third person is Meena Sawant ma'am. Ma'am is a senior consultant in HOD Department of Obs and Gynae, Kunj Holy Family Hospital, Pune. She is the GC member ICOG 2023 and 2025 and was also the President Patna Obs and Gynae 2023 and 2024. May I request one of the chairpersons to please welcome our speaker, Shashi Bala Bhosle ma'am.
Okay. So good evening, everyone. I take this opportunity to welcome Dr. Shashi Bala Bhosle, a very dear person. She's the Governing Council member ICOG 26 to 27, founder president Gwalior Menopause Society 25-27, and chapter convener Association of Medical Women of India, national coordinator IAEC committee FOGSI, and holds many important positions and has various achievements.
Thank you. Yeah. Thank you so much. First of all, I bring greetings from Gwalior and my respects to Sheila Madam, Sadhana Madam, and Dr. Pratik Tambe, and all my ICOG GCM members are here, and breast committee is like a homecoming to me. It is thanks to Sneha and Dr. Archana who introduced me, who just embraced me for this committee, and I am here. Come what may, I'm always there for the breast committee. And my regards to Mangalavani. I just heard her, and Dr. Lakshmi. My God, to be in their company and be as a speaker is giving me little goosebumps. So goosebumps, I must say. And thank you, Dr. Meena. She is my most favorite person of FOGSI, Meena Samal. I always look up to her and for this introducing me. And I can see Charu, I can see Divya, I can see Taru, and all girls there. And Dita and Deepa, thank you so much. And Niva, it's your thing that you encouraged me, and I'm here now. Without wasting time now, I think I should just share my PPT. And yes, now I've been given this topic, no milk, poor lactation. And
full screen, please.
Yes, make it full screen, please. Nibha, please make it full screen.
Yes.
Whoever is sharing, yeah. So don't panic. Like no milk. Just hearing that, I can see Vidya Thobi man. Greetings, Vidya ma'am, and Abba Sinha ma'am. First thing that comes to mind is panic, and this is what these girls do. They are first-time mothers, or they've just gone through that postpartum, and they've just delivered. So they just tell them Don't panic. No milk, no milk. They'll keep on hammering into us. So first check, we have to see, don't label it as no milk. You have to give. And what people do, when they start this, they start giving formula immediately. They give honey, they give good tea, water, sugar, whatever they can have their hands on, but for breast milk. And they will give cow's milk, they will give lactation food and whatnot. And this, but whatever you give, but you don't stop breastfeeding. So, practical clinical approach, whenever a patient approaches you with that, I have no milk, or what she says that milk is not there, first thing you do is assess. What do you assess? Baby is feeding. And as my co-speakers have already told you, urine, stool output, and weight. These three are very important assessment factors that we have to see. And then observation helps a lot. Observe a complete breastfeeding session. Ask the mother, okay, chalo, come on, you start. I'm there. Let me see what exactly you're doing. And then when she is breastfeeding, just check on the latch, just check on the positioning, and just check on the milk transfer. That sound comes, that's such a reassuring sound when the baby is taking milk, that really gives a great relief. So colostrum is small in volume, but chota hai, lekin sufficient for most healthy newborns. Next, please. So what you do after assessment, next slide, please. We do assessment both mother as well as the baby. Breast examination, as Lakshmi Madam said, right from the antenatal period. If you have done the breast examination, then it is easier for you. If there is any previous surgery or any breast surgery, or she's having any endocrine diseases, this can really, or she's on any medication, they can hamper a little bit. So we have to assess that. And for the baby, latching position, swallowing, urine, stool, and weight. So complete assessment, if you do, you will have a better care. So next, please. Now, after assessing, what do you do? Find out the cause. Naturally, what is that which is such a natural thing and it is not being there? So for mother, you see whether she is under stress or exhaustion or pain. Sometimes there is pain, sometimes there is stress, and there is stress of the in-laws and stress of not able to feed the baby. That stress is very killing. Mera bachcha, main doodh nahi pila pa rahi. So that is a very big strain on the mother. See if she is exhausted. Whenever she sits for breastfeeding, she should be well fed, well hydrated, and sitting comfortably. So that you have to see. Then if she's any drug she's undergoing, or she has undergone cesarean section. Cesarean section, they feel is a very thing कि उसमें दूध आता नहीं है. That is not the case. इसमें कोलेस्ट्रॉल तो आएगा ही आएगा. And diabetes can interfere with milk production. Obesity, again, excess weight may affect the hormones and the milk supply. Or if she has undergone PPH and she's anemic and she's lot of blood loss is there might be little, it is very taxing, lactation. It is very easy to say breast milk karao. Lekin breast milk is very, very taxing. So the feeding is very, very taxing. So you have to keep in mind whether she has had any PPH, she had some retained placenta, which can lead to any infection. She must be having fever. So that also one cause of delayed lactation, or she might be having hypothyroid, where all the metabolism is very slow, or hormone imbalance is also there. So next, please. This can be the cause in the mother. And for the baby, there can be some local cause with the baby also. Next slide, please. Infant, again, poor latch. They have to be taught. They know, they have that rooting reflex. They will go and find the mother. But if their nose is being pressed or they are uncomfortable, then naturally they would not be able to take it, or there is tongue tie, or the premature baby, or the sleepy baby. See, out of 24 hours, 20 hours they sleep. There is a gastrocolic reflex. They feed and they pass stool. So they like to sleep also, and they want their mother also next to them. So all these can may cause poor breastfeeding. So next, please. So what do we do? Correct the basics. Now, what are the basics? Next. Yes, basics. Next slide. Yes, correct the basics. In Skin to skin contact. I want to have this next slide. Skin to skin contact should be there. Please change the slide. Can you please change the slide? Yes, yes. Now stay put. Correct the basics. That is our immediate requirement. Skin to skin contact. Just bring the baby to the mother. Baby needs that mother. Feeds on cue frequently. Let it feed frequently. What's the problem? Offer both the breasts. Use breast compression. If baby cannot transfer the milk, you can do hand compression or you can use pump also. But avoid unnecessary formulas, bottles, or pacifiers. And to ensure latch and effective suckling, then you have to have a wide mouth. I think that has already been discussed by this Mangla madam. So lactogenesis we must know before. अपन बताना easy है कि भाई breastfeed करो, but how is the lactogenesis journey to breast milk कैसा होता है, that we must know. There is stage 1 which begins during pregnancy. There is a colostrum formation. And in the second stage, 30 to 72 hours postpartum, it is triggered by the placental delivery, and prolactin and oxytocin, those three hormones, they will help. And in the stage 3, there is supply and demand physiology. If you supply, then there will be more demand. So frequent milk removal will maintain the milk production. Next, please. Next, please.
Yes.
Yeah. Now, why mothers think? Now you have to go into their psyche. Why they are not stupid that they are saying I have no milk. We have to see why they are thinking. We have to be in their shoes to understand that. See, colostrum, they don't identify until and unless you counsel them. Volume is naturally small, so they think the baby's first need it is sufficient for the baby's first need. We as doctors we know, but they don't know. So frequent feeding is normal. That also they must know that newborns feed 8 to 12 times or more in 24 hours. It helps them build a good supply. And the pump output is directly proportional to the milk production. So what you pump out is not your always equal to what your baby gets from the breast. So you have to see pump how much is being given to the baby. And above all, the baby wants comfort. She will just hold your skin, or she will just hold your on the chest. She'll put her hand. So you have to make the baby feel secure. That is very important. And unrealistic family expectations again are there, which make the mothers think that they are not having milk. So the signs that your baby is getting enough milk, you have to see 6 or more wet nappies, as she said, langots. Then active and alert baby is there, then you don't have to worry. And after the feed, she sleeps well. So, and regular soft stool, that gastrocolic reflex should be there. That shows us that the tummy is full, and then the baby passes the stool. Next, please. So, common complaints: no milk, only few drops, baby cries, breasts are soft. Actually, the breasts are soft. This complaint, we must correct them immediately. It is a sign of well established milk production, and lactation is established. Baby feeds all the time. That means the baby is doing well. Milk came after C-section. This is not milk. Before that, there was colostrum, and milk dried after stress. Milk does come out. It is all in your head. So baby is losing. So you have to keep on doing RI. Not you just not say nay, no. There is a positive response. Positive feedback is there. So you are here. You must tell them, don't worry. So perceived versus true milk supply. So there is sometimes they perceive that there is less milk supply, but actually it is what? It is only perceived. What is cluster feeding? Cluster feeding is also is perceived as low feeding, but it is a normal newborn behavior. Cluster feeding, it satisfies the baby's hunger, it stimulates the breast and milk production. And this is a very good sign. Crying baby doesn't always mean the baby is crying for milk. There are some other causes also for the baby to cry. Soft breast, as I told you, signs of established lactation. Short feeds doesn't matter. Frequent feeds doesn't matter. They are perceived as low milk supply, but they are not. And So the true blood, true low supply, when you should be on your guards, when you should see, that is a poor weight gain. If the baby is not gaining weight, less than 6 wet diapers per day, that means she's having dehydration, hypernatremic dehydration, and delayed lactogenesis. So you see, this milk is also giving her hydration. We don't give water till 4 months. We are total breastfeeding we have to give. So even water is not needed for a baby. Breast milk has enough of water. So now if the supplementation is medically indicated, then what do? Mother's express milk, first we try, then we try the human donor milk, and then we can also give formulas where appropriate in this manner. First mother, then donor, then formula. But in spite of all that, we must protect and maintain lactation whenever the feed is supplemented. So continue the breast stimulation while emptying, and whenever the feed is supplemented, do not stop breastfeeding. Next, please. Uh, Next, please. Yeah, you can also give. Niba, can you make the last slide? I would like to. Yes. So the take home message would be, don't treat the mother's perception of low milk supply as it is low. First, you have to assess, identify, and improve. There is room for improvements. So, assess the milk transfer, identify the cause, and improve breast drainage. That will always, the mother will come back to you smiling and will tell you, thank you, madam. I got, there was just confusion was there, and the milk is proper, the baby is feeding well. And so, you will have a grateful mother and a baby. So I think that's all. You mother and the baby, the triad should be there, not alone the baby and the mother. We should equally be there with every baby, every mother when they are breastfeeding. I think thank you so much. Thank you.
Thank you, ma'am. May I request the chairpersons to give the final Vidya, ma'am?
Is Divya there?
Vidya madam is there.
Vidya Tobi ma'am is there, ma'am.
Madam, you're muted.
Yes.
Vidya ma'am, we cannot hear you.
Hello.
Yes,
ma'am. Yes, ma'am.
Yes. Good evening, everyone. And it was really excellent talk.
Thank you, madam.
And very vibe means you put your heart, brain, soul, everything in the talk. So whosoever you will be counseling, I think you are a best counselor and best promoter of breastfeeding, I must say.
Thank you,
The
madam.
poor lactation is very common complaint. And many times they tell that even then we take lot of nutrition, lot of this one, but the main thing they forget is the latching. The latching, and first they start the breast milk itself is a trigger for more milk and all, and they will not be able to see how much baby is sucking the milk. So every time they feel that it is inadequate. So for that proper counseling is required. Thank you very much for inviting me on this platform, and hearty congratulations to the organizers, Dr. Nibha, who is a breast committee chairperson, who is doing excellent work, and I must thank the ICOG and this one, Dr. Pratik as a secretary, and Dr. Sheila Mane as a ICOG chairperson. Thank you very much.
Just
All
one
the
line
three,
I would
I
like
could not
to add.
listen to
Yeah.
previous two talks, but definitely they must
One
be
line just I want to
excellent
add,
only.
because we
Yeah.
all are there in the
Yes.
Aduna.
Excellent talks.
Skin to
Yeah.
skin contact.
Yes.
And that first, that our golden hour, just to emphasize that here. Yeah. Thank you very much. Thank you, Nibha. Thank you, Sheila ma'am and Dr. Pratik, for this very opportunity to be here with you today. Thank you so much.
Thank you.
And
Thank you so much, Chairperson.
one more thing. We conduct deliveries, but we don't conduct breastfeeding sessions. So that first session of the baby should also be conducted by an obstetrician. That is what I would like to say.
Yes, that's what we taught them, that delivery should be completed, not only delivering the baby placenta and doing episiotomy. It's completed after the first breastfeeding starts. So that's what we taught them.
Thank you.
Thank you, everyone. Thank you, Dr. Pam. Thank you, all the
Thank you for sharing. Thank you for sharing.
Thank you. Finally, I could do it.
Thank you so much. With 3 sessions completed, we have come to the last and the most interactive session. That is the panel discussion. And the panel discussion would be on the breast breastfeeding and challenges. And it is my honor to invite the moderators, Sneha Burya ma'am, who is the Managing Director, Sukharta Hospital, Maternity and Nursing Home Fertility Center, Yatlam, and she has 32 years of experience, and she has held 2 national posts for FOGSI Chairperson Breast Committee and also the GC member ICOG. Ma'am, can I have the second CV? The second moderator for the session is Taru ma'am. She is the consultant and director, Bansal Hospital, Shyamnagar, Jaipur. She is also the honorary secretary, Narchi State Branch, Rajasthan. And also the West Zone.
We are short of time. So
thank you, ma'am. And the expert for today is Divya ma'am, who is taking breastfeeding and all the sessions on breastfeeding to a new height. So, ma'am is the National Coordinator for Breast and Puerperal Health Committee, FOGSI. She is also the Chairperson of Community Health and Public Forum Subcommittee, AOGOD Delhi, as well as the Chairperson Breast Cancer Awareness Mission, NIJF. Ma'am, I request the moderators to please take over the session and invite the panelists. Thank you, ma'am.
Yeah, thank you so much, Dr. Mehta. A very good evening to all of you. And at the outset, I would like to thank the team ICOG as well as team FOGSI Press Committee to have all of us on board. Thank you so much. And may I invite Dr. Anita Rajuria, our own member of Breast Committee when I was the committee chairperson, and a very close associate and a very dear friend, Dr. Anita, now who is the Governing Council member. Welcome.
Thank you, ma'am.
Yes. Next, Dr. Meeta Gupta, who is the Dean Academics, Professor and Head of Department of FOGSI, Jammu. We welcome you, Dr. Meeta. Next, Dr. Charu Modi, again, a dear friend and a member of our committee, very vibrant personality, actually conducting many sessions on breastfeeding and promotion as well. So welcome, Dr. Charu.
Thank you so much, ma'am.
Dr. Deepa Gupta, Governing Council member, ICOG, President-elect IMA East Delhi, and Chairperson for Public Awareness Committee, AOGD. Welcome, Dr. Deepa.
Thank you, ma'am.
Dr. Shilpa Kshirsagar, I think here she's the lactation consultant, yes, and Professor and Unit Head in the D.Y. Patil Medical College, Pimpri. So welcome, Dr. Shilpa.
Thank you, ma'am.
Dr. Lalita, HS, consultant at Shri Women's Care and Fertility Center, Tumkur, and I think Breast Committee member, working very hard nowadays. I can see her post. Welcome, Dr. Lalita.
Thank you, ma'am.
So, without much ado, because of short of time, I think we should go ahead with the much awaited session of panel discussion. I hope you all can see my slides, and I hope they are full
Yes,
screen.
yes.
Yes. Okay. So thank you so much, all of you. And just, we have been talking about breastfeeding. I think 1st to 7th August, this is not the only week where we should talk about. Breastfeeding is such an important issue that we should keep on discussing it 365 days a year and 24 hours a day, I would say. So definitely it is very important. How you will come to know during the discussion. So it's actually sucking of the baby at the mother's nipple or mother's breast, I would say. Exceptionally, the expressed breast milk, also we call it as breastfeeding. All of you know that it is a neurohumoral reflex. When the baby sucks at the nipple, there is a sensory signal that reaches the posterior pituitary, causing release of oxytocin as well as prolactin. So prolactin is actually responsible for the baseline milk production, and it is the oxytocin which is responsible for the milk letdown. And so, though it is a complex neurohumoral reflex, it is actually a very emotionally bound or emotionally related reflex. So, without going into much details, I would just go ahead and let you know that, it's the worry, anxiety, pain, stress, and doubts. These are the things which actually hinder this reflex, and it's the the emotional status of the mother, which is actually pleasant and is well informed, well confident, so that will help stimulate her oxytocin reflexes. So I would like to ask the panelists, we will start one by one. I think we can start from Dr. Deepa. What are the UNICEF and WHO recommendations for breastfeeding?
Ma'am, we have already discussed this thing. It has to be started as early as possible, immediately after birth, even in the labor room or in the OT. The first golden hour is the most important thing.
Yeah, we will not talk about the details. The talks are over. What we have to know is the recommendation 1, 2, 3. That's all. As you rightly said, yeah, initiation as early as possible. 1. And
then it has to be continued for 6 months, exclusive breastfeeding.
Right.
And after the 6 months, we can start the complementary feeding, but the breastfeeding has to be continued for 2 years and
2
more.
years and beyond. Yes, yes. Very correctly said, because we wanted to give very precise message. As you can see, that initiation as soon as possible. It's not only the first golden hour, but as soon as possible. And that's the very reason we talk about the Ma initiative by Government of India, the mother's absolute affection, where it is in fact recommended to deliver the baby on the mother's abdomen and leave the baby to breast, so that the baby crawls towards the breast and starts sucking on its own. That early it should be the initiation. So what are the, now I welcome my dear friend Dr. Taru and hand over.
Thank you,
to her.
Dr. Sneha.
Yeah.
So, after so many important sessions, everybody knows this. What are the benefits of breastfeeding to baby and mother? One by one, I want to ask benefits for the baby first. Dr. Charu Modi.
Yes, ma'am. In fact, as we have been listening, breast milk is the first vaccine of the baby, because breast milk contains everything what a baby needs, what a newborn needs. It should be exclusive, and it is the first milk, that is what we call as colostrum, is a good source of immunoglobulins, and it helps in various cognitive development and overall development in correct functions of all the systems of newborn, be it be neural development or the gastrointestinal functions. It reduces the chances of various diseases like SIDS and Hodgkin's lymphoma. And it also reduces the chances of infections in the baby, like otitis media, then necrotizing enterocolitis, bowel diseases. Then if a mother is exclusively breastfeeding the baby, it helps in promotion of the bonds between
Very
the
correctly
mother.
said. Overall development of
Yes,
baby is
overall
very good
development of the
because
baby.
immune system is
Right.
improved because of breast milk. What are
Right.
the benefits for the mother? Dr. Anita Rajoria.
Pardon, can I?
Yeah,
Hello?
please.
Yeah, benefits of breastfeeding to mother, Dr. Anita.
Yeah, mother also gets benefited because, you know, whenever she is breastfeeding, it causes uterine contraction, which helps in postpartum involution of uterus. And whatever mother has gained during pregnancy, if she's breastfeeding the baby, she will lose the weight readily. And if mother is having regular breastfeeding sessions, at least one in night time and 5 or 6 times in the day, it may act as a contraceptive also, but you have to tell her that it has to be exclusive breastfeeding. No top feeding is allowed if you consider it as contraceptive. And it is more so for first initial 6 months till the mother is amenorrheic. Then, as madam has already told, there is decreased risk of breast cancer. And moreover, it is so good for the environment. It is readily produced. No carbon printing is there, no factories, no transport, nothing. So it is there whenever the baby needs it. So it's so good for environmental also. It's economically viable option also, because mother has to have just good nutrition. See, she doesn't have, or the family doesn't have to spend anything extra for that. So I think
Thank
it
you,
is
Dr. Anika.
good for
Very nicely explained everything. Dr. Deepa, what type of breast milk we do have?
Initial phase is colostrum. It ideally starts in the later period of the pregnancy, and then in the first 4 days is the colostrum. And that is the ultimate vaccine, we say, that is the best milk a baby can have. And it's very rich in protein. Then we have transitional milk from about 4 to 10 days, a little of less in protein, but it is definitely a very good nutrition for the baby. And the third one is the mature milk. Then we come to that is the fore milk and the high milk.
Thank you so much. Dr. Sneha, now your turn.
Yeah. So I would now go ahead with the discussions, especially the practical challenges in breastfeeding. And that's why I wish to bring in the lactation consultant, Dr. Shilpa. Do we have Dr. Shilpa here?
Yes, ma'am.
Okay. So what are the practical challenges you feel that you face in day-to-day practice, and how do you tackle it?
Yes. So first and foremost, breastfeeding challenge we come across is about the latching and the attachment of the child or the fetus. Second is most of the mothers, if there is no proper latch, then they might face the sore nipple, cracked nipple, these kind of problems. It is followed by inadequate milk supply, or the need for top up feed is the usual complaint. Also, there can be problems associated with the baby as well. For example, if the baby is having some oral abnormalities, cleft lip, cleft palate, or simple tongue tie, lip tie, so these problems can also be there. And of course, if the obstetrician or pediatrician is not aware about the progression of engorgement, mastitis, and breast abscess, then we can have those problems as well. Then there can be infections as well. For example, candidiasis infection can be there. And the one more problem which we come across many times is related to the drugs. So most of the lactating women come to us asking, is this drug can we take during lactation, or should we stop lactation? These kind of challenges also we face during the breastfeeding consultation.
Yes, very well talked about. So it is mainly the initial difficulty in the poor attachment, initial difficulty in the attachment, where the baby may not have the appropriate attachment or deep latch, as we call it as. And the problem may be either with the mother who is not trying to attach the baby properly, or the baby itself may have as she said, tongue tie, or even poor sucking reflex, even maybe the obstructed labor. And the problems with the mother's breast, that is the flat or inverted nipple and cracked nipple, even sometimes the plugged duct and engorgement, mastitis, and breast abscess, so many other things. So what do you think, Dr. Meeta, is the cause of this? Some, as we have already discussed, that some of these mothers, they start saying there's no milk, the baby doesn't suck well, and the family members also start supporting them in saying, not in actually supporting them to help attach the baby properly and support the baby to feed properly, but in fact they keep on just saying that it is not adequate. So what can be the reasons, Dr. Meeta?
First thing that we have to make us parents, as like patients, understand that it is always usually the fault where the mother is not trying because of pain, maybe after cesarean or normal delivery, she's not willing to latch the baby. This is the most important, where we have to, as obstetricians, it should be our duty that we have to make the mother that please latch the baby, and have to assist her how to latch her. If the first thing this we do it, probably this feeling of the patients that we are having inability to breastfeed would be taken care of. Very rarely, ma'am, because of maybe excessive bleeding or postpartum, but she had in previous pregnancy, if she has had a episode of PPH, and maybe the patient has developed, but these are very rare, and these are just for academic purposes that we are going to put it over here. But usually the fault is always with the initial lactational failure, where the mother does not latch the baby, or is the second the pain relief is not good, those two things are the most important things that we have to take care in the initial postpartum period.
Right.
Then once
Exactly. Yes.
Stress and anxiety, as madam showed a beautiful slide initially, stress and anxiety can itself cause inhibition of
And the doubt, that is also one more thing. So very rightly said by both of you that in fact failure of lactation is a rare situation. The milk may be inadequate because you are not feeding the baby properly, or you're not attaching the baby to the breast properly, where the effective sucking and milk transfer happens. Okay, so that can be the only reason. Otherwise, the doubt. Yes, the doubt which the mother has and the doubt which the relatives put in her mind, that disturbs the psychology, and that hinders the oxytocin reflex, which in fact lead to poor or inadequate lactation.
Yes,
So what is
lack
the
of
correct?
confidence.
You have heard the talk, you have heard the talk, but I would ask Dr. Lalita, how do you actually tell your patient to go for the deep latch or effective latch? Please unmute yourself. Unmute yourself. You have to click on the, yeah, right.
Yeah, I got muted again. I unmuted. Okay.
No problem.
Hi, good evening, everyone. One simple thing, one good example for a poor and a big latch is, if there is a good latch, I tell my patients the baby will touch the nipple like this, where the mouth is widely open and it is containing most of the areola. Whereas if it is a poor latch, poor attachment, then it will attach to the nipple like this. Only one finger is allowed, not mouth widely open, and not areola is attached. Only the tip of the areola is attached to it. This is a simple thing and they easily understand. Otherwise, the nipple, both the tongue and the lower lip should be below the nipple and covering most of the areola. Most importantly, below the below part of it.
Yeah.
So this is what it
So,
is.
to make very correctly described, but just to make the patient understand, sometimes what you do is, if the baby is not opening the mouth widely, then you just try and touch the baby's nose with the nipple, and the baby opens the mouth widely in search of the nipple, and then you straightway put in the nipple as well as the areola. So this is the effective or the good latch. What are the contraindications for breastfeeding? I would ask now again, Dr. Deepa and Dr. Charu.
As it is, there is no absolute contraindication for breastfeeding unless
Right.
the patient have some active disease, like she is a active tubercular patients, or there is a active HIV disease which is not on antiretroviral
Right.
drugs. Then this would be
HIV patient on treatment agreed that she can definitely breastfeed. But do you think that active tuberculosis is a contraindication?
Ma'am, if she is she's in an active stage and she's not been treated, or she has just started the treatment, I think, or it can be, it's not an absolute contraindication. This could be,
exactly.
yes, absolutely.
So HIV patient on treatment and active tuberculosis with good respiratory hygiene and on treatment, she can definitely
She has to just wear a mask while feeding. She has to just wear a proper mask.
Respiratory hygiene, yes. So she has to wear the mask. And of course, this is just a relative contraindication. This is not an absolute contraindication. So what are the absolute contraindications?
And sometimes the baby might be having certain inborn errors of metabolism.
Right, like?
That can be a problem. And also if the mother is on some anti-cancer drugs, some radioactive isotopes she's receiving, so that also becomes a, contraindication for breastfeeding.
Perfect. So what kind of inborn errors of metabolism you don't allow the baby to?
Lactosemia.
Yes.
The lactosemia, lactose intolerance, right? So this is the one which, the baby gets very severe indigestion and lactose intolerance, if at all it has, right? So all of you have covered it well. So Dr. Taru, you can go ahead
So
with the
we now start with few cases. There is one lady who comes low risk preemie, just delivered today. Now she is complaining of blood stain discharge from the nipple. Then how will we proceed further? We have to examine, evaluate, and counsel her. But how? Anyone, Dr. Meeta?
Thank you, ma'am. At first, we will first examine the patient because she is newly delivered. Probably her latching of the baby was not correct. And that was the basic reason in most of the cases where we would look that probably there is a cut or somewhere at the nipples. This is the first thing that we have to make the patient understand, that please clean your nipples before feeding the baby. Every time you have to clean it with plain water. And then after you have fed the baby, probably use an local antiseptic cream so that this local cut would have been healed. Usually they are, because once they start having it at one, they will stop from that nipple and then again start feeding from the second nipple. Because of that, both the nipples will usually develop. So we have to counsel the patient that this does not require much antibiotic therapy, only breast hygiene, which involves cleaning of breasts before every feed. And then after feeding, they clean it and then apply a local applicant. That would be one. Unless until she develops fever or maybe some pain during her nipple breastfeeding. These are the two danger signs that we have to make the patient understand.
Dr. Meeta, yes, but we have to examine the patient also. See, maybe possible the lump is there and that may be earlier also present, and patient must have forgotten to tell also, because the patient has suddenly come and delivered to us. So we have to examine the patient whether there is some lump or some problem at the nipple, not only because of cuts, maybe something else also. So we have to rule out everything and counsel. Don't get worried, we are there for you. What else? What can be the differential diagnosis? Dr. Charu? Yeah,
Pregnancy.
Dr. Anita?
Pregnancy associated breast cancer. This can be one alarming situation which we tend to often ignore. We just pass it off as mastitis or just nipple irritation is there. So these two things are important to be ruled out. As very well highlighted by Dr. Taru, examination is very, very important. So we need to see whether it is unilateral or bilateral. Is there any underlying lump? What is the skin around nipple? How does the areola look? So all these things, is there any puckering or any distortion of breast symmetry? Everything, like we have been taught so well in so many
90% cases, the blood stain charges just normal because of some injuries or some crack. But in few cases, maybe because blood stains, the mothers are alarmed, they are stressed. So we have to counsel them.
I think that is the time where we have to invite Dr. Divya Singhal, who is our expert. I would just make one comment here, that it's not only the cuts and nipple crack and all these diseases. 90% of the cases, this is a physiological discharge, and which happens because of the congestion. So you just allow the mother, rather encourage the mother to breastfeed, and see that over 24 hours it disappears. Okay.
Wrong cultural practices also, ma'am. Sneha, ma'am,
is,
wrong cultural practices, expressing very fiercely the breast.
Very vigorously. Some of the women, they just massage it so vigorously. They compress the breast so vigorously. That's the reason. But it is simply that the physiological congestion, and it's just a little blood stain discharge. But if it is associated with ulceration wound or the lump, that needs evaluation. So Divya,
what is your
comment
take?
for?
Yes,
Yes,
electronic.
This usually goes away in 24 hours time, like you rightly said, because it is a natural. Sometimes there is a papilloma, a duct papilloma, but most of the time this is due to congestion and it disappears. Just have patience and give some time to the mother and the baby. It will disappear. Thank you, ma'am, for asking me. Over to you.
Perfect. Yeah, definitely. We would like to have your comments also later on, Dr. Divya. So we go ahead with the second case now. So
This
let us
case
go
is a 32 years old preemie. She delivered 10 days back. She reaches the hospital with complaints of pain in breast. also claims to having difficulty in breastfeeding too. What can be the causes for difficulty in feeding? How will you proceed? Anyone can answer. Dr. Shilpa?
Oh, okay.
Yeah,
Uh,
Shilpa, Lalita.
Yes, ma'am. She is a primee who has delivered 10 days back, and still she has difficulty in breastfeeding. So, first, I would think of a natural thing like physiological, that she has yet not understood the deep latch, and that's why she is having pain. This deep latch is not, she has not achieved it, maybe because she has some nipple problem like inverted nipple, or because of the because she has not achieved good latch, she might have cracked nipple, sore nipple. On day 10, there is also a possibility that she has progressed from engorgement to the mastitis or breast abscess. Third possibility is baby is having some kind of oral abnormalities, and that's why baby is unable to latch. And as the baby is unable to latch deeply, she is having pain. So these are the most common three DDs I would have on day 10 of her postpartum, day 10.
Dr. Divya, you want to add something to it?
No, I think Dr.
No,
Shilpa is perfect answer.
Yeah.
Thank you.
Dr. Charu?
Yes, ma'am.
Can a woman with inverted nipples easily breastfeed, or some kind of difficulty she's facing in it?
Ma'am, actually, before labeling her as inverted nipples, I think it's very important that whenever a pregnant female comes to us during antenatal examination, we should tell and we should examine the breasts also that time. If at all we see inverted nipples that time, nothing, no, I mean, no manipulation has to be done. It's sometimes, most of the times, the nipples, they ultimately form during the later stages of pregnancy.
Perfect.
Or if they are still inverted, actually they are not. But when the baby starts suckling, the nipples are become formed, and the baby is able to suckle easily. We have to really distinguish between the false inverted inversion and the true inversion. When the areola is squeezed and the nipples are formed, they come out. That is, I mean, a sort of a false inversion. And even after pressing, the nipples become inverted or they don't pop out. That can be a true inversion. But we have to tell the mother that no need to worry, don't squeeze, don't manipulate. They will form automatically. Once the baby starts feeding, the inversion will automatically get corrected.
What is the
That
role
is
of
why,
areola?
yeah, that is why it is called breastfeeding, not nipple feeding, na? So
Right.
the baby latches,
So,
yeah,
Actually,
I think
baby
it's a
latches
good
to
way
the
to
breast,
remember.
not the nipples. So
so yes,
we have to
perfect.
tell her,
So
we
the
have to
message
really
here,
counsel her.
yes,
Yes,
we
ma'am.
the message which I always give for this is the baby latches to the breast and not to the nipple. If
Right,
it tries to latch to the nipple, she will have nipple cracks.
right.
Okay, and
Yes.
there will be no effective milk transfer because the all these lactiferous ducts, they gather at the areola. Okay, they drain at the areola through nipple. So the baby has to suck at the breast, not at the nipple. That is what we have to say.
Yes, ma'am.
Okay,
Yes,
so
your turn now.
yeah.
Ma'am, I
Now we
just
go
want
ahead.
to interrupt Dr. Sneha, ma'am. We need to
Yeah,
wind
please.
up by 7 p.m., ma'am. So case will see the accordingly.
Yeah.
Thank
So
you.
directly we go to the last case now. We have important discussion here. We have this lady delivered 5 days back, and she comes to you with fever, with chills, and tightness in the breast, very painful breast. You can see the tiny, the shiny enlarged breast. When you try to see, there's no nipple flowing, and this is the picture. What is your diagnosis, and how do you go ahead with the management? What do you think? Why this has happened, Dr. Lalita? Yes,
Breast
Dr.
and
Lalita, yeah.
yeah,
Dr.
breast
Lalita and
engorgement.
Dr. Meeta, I think they are remaining too.
So, if she has started feeling pain, maybe it is because of the breast engorgement. The breast seems very full in comparison. The other one is not seen. You can see the difference in the size also. The breast become
Yeah,
engorged.
so
You
the
can see the
diagnosis is
dilate
perfect. We
breast
are
engorgement.
asking
Yeah.
why it has happened. Dr.
Yeah.
Meeta, why has it happened?
Ma'am, probably she did not feed the baby on time because this breast filling, refilling takes some time. So
Yes.
if normally we do not feed the baby on time as and when the baby demands, that is the time this breast, usually by 5th, 6th day, once it is fully established, every 3-4 hours, the baby has to be fed. In case it is not fed, this letdown is too high and this keeps on causing engorgement of breast.
Yes.
The most
And
important.
moreover, there is one more social issue. Suppose the baby is the baby is lying towards left side. She'll keep on feeding from the left side, and she will have she will be lazy enough to change the side or feed from which will lead to the engorgement. It may be a simple reason, but she
Yes.
has to be told that she has to feed alternatively
Yeah.
from both.
So ultimately, it is the complete unrestricted feeding. Okay, what we have been first and foremost, delay in initiation. See what message we have been giving, that since last almost 5 to 7 years, whether it's a vaginal delivery or a cesarean delivery, we are almost delivering the baby on the mother's abdomen and feeding the baby then and there only. So any delay in the breastfeeding or initiation of breastfeeding, poor attachment as we have been discussing, and infrequent removal of milk, maybe on one side, maybe on both the sides. But the restricted feeding, as you said, during the first few days after delivery, it is 1 to 1.5 hours, not even 3-4 hours, right? The baby feeds very frequently during first few days. It takes only small feeds, but it takes frequent feeds. So frequent, complete, unrestricted feeding. That is what the message should be, very loud and clear. Now you have this patient who has already developed breast engorgement. How do you treat it? Dr. Lalita, how do you treat this patient?
Now
Engorgement.
so the mother is in pain. She's having fever.
Lalita,
Okay,
I can't see her.
Yes,
Dr.
ma'am.
Lalita?
I'm here very much. It depends what stage it is, whether it is just a engorgement or it has gone
It
to
is engorgement. It is engorgement only. How do you treat?
yeah. Hot compression can be given. Alternate cold compression also can be given to relieve it. And when it becomes little soft, then slowly it is extracted, and further accumulation is prevented by keeping it compressed, and further, and even the Ayurvedic, like the Malika and all these things also help. They tie it up. Little
No.
compression and
Here,
further expression is not done. So
okay.
that more expression will lead to more milk secretion and further engorgement. So this is
Yeah.
prevented. But
Yeah.
the what is already there should be emptied first.
So the
And
simple solution to this is, just ask the lady to have a hot, warm shower. Just have warm shower. Just pat her on the back, relax her a little, ask her to do the massage on her own. You don't try to force anything,
yes,
because that will further worsen her pain. So massage her, ask her to massage herself, and gently you can see how the four fingers below and the thumb above, gently you try to express the milk, not extract actually.
ma'am,
Express the milk.
sorry to disturb
Okay.
you. Can I show, because most of us don't know how to do breast massage and
Yeah, that is why I think if at all we have the demonstration, but this is what we are trying to show. This is very gentle massage. You can see the lady is doing with her four fingers. And can you, is it Dr. Shilpa you want to show?
Yes, ma'am.
Yeah,
First
please
of
go ahead.
all, about the engorgement, you have to express the milk. You cannot keep the milk like that. What
Yes.
ma'am said is correct, that if you express more, then she will produce more. But
Yes.
but it has to be expressed. It should not be emptied, but it has to be expressed. Second thing, while before expressing, she should do the breast massage first to the areola and the breast as well. So if most of the time it is the periareolar edema which does not allow the milk to come out even if you are doing breast massage. So first you have to reduce the periareolar edema. Just make a flower of your fingers and give gentle pressure for 1 to 2 minutes. That reduces the periareolar edema. Then give the breast massage where you hold the breast in your two hands and just do the churning movement gently. The pressure shouldn't be so much that she will feel the pain. Okay, I always tell, do not directly go to the breast, as ma'am rightly said. Just relax her, talk to her, give her massage to maybe back, her neck, just pat her back. All this helps to reduce more and more oxytocin. The hot water bath or the hot water fomentation can be given before the expression, and cold fomentation has to be given after after expression. So cold is to reduce the pain. It should never be given before expression. It should be given in between the expression. That reduces her pain. So this you have to remember, this is reverse pressure softening, which reduces the periareolar edema, or this simple massage from all the side, or you just remember the principle of from going from chest wall to the nipple, chest wall to the nipple. Simple this way. And while expressing, hold at the areola where the areola ends. Do not hold here. Hold where the areola ends, go back towards the chest wall, and then come and squeeze towards the nipple. It should be never like this. Okay, so first you have to hold where the areola ends, press towards the chest wall, and then come and squeeze towards the nipple.
Yeah, the reason I have already told you that the lactiferous duct, they drain there near the areola, and through the nipple the milk comes out. That's the reason whenever the baby is sucking, it has to attach to the nipple and the areola and not the nipple. And that is similarly when you are expressing the milk, same principle applies here. So hot compresses or shower before expressing, and cold compresses after you complete. So if you can do it with your hand, well and good. Otherwise you have these various devices, manually operated or electric operated or battery operated, right? Now what is this? Anybody can take up. Dr. Deepa?
Neha ma'am, we
yes.
will also have to, because the time has finished, we'll also have to wrap up.
Yes, we are going.
Thank you so much.
So this is a rapid fire for you. Thank you. What is this and what is the treatment?
Sore nipple, it is sore nipple.
Yeah, cracked nipple,
The
sore
best
nipple.
treatment
What is the treatment?
Counseling for proper latching and how to breastfeed, and then patient or the mother, breastfeeding mother, can just put the last drop of breast milk on it.
Yes,
And
let
that
it
is
air
sufficient.
dry. Let it air dry. So the very important message, only message here is not to clean or wash the nipples repeatedly.
No soap, yes.
Absolutely not to even wash with water.
I
Let
agree, ma'am.
the milk air dry. Yes.
It should never be washed. Whatever she is doing at the time of bath, that is enough. It is not necessary before every feeding.
Yes, that is the most important message, that not to wash it repeatedly with soap and water. In fact, let the milk air dry on the nipple. It will heal spontaneously, naturally. Otherwise, little lubricant like nip care or nip heal ointment should be okay, but you need not wash it every time. What is this? What is this? The Dr. Deepa, Dr. Meeta, what is this picture? All three pictures, the mother is feeling severe burning, stinging pain. But sometimes you find this angry red picture, sometimes you find little redness, but sometimes you find the breasts are absolutely healthy looking. But the mother gets severe pain. So this is
the burning of the candidiasis of the
yes. So this is candidiasis. So you have to look for the oral thrush for the baby also. Treat the mother and treat the baby simultaneously. We will not discuss this treatment because all of you know this. What is this? Engorged mastitis. Yes, mastitis. What is the treatment? What is the treatment?
And we don't have to stop breastfeeding. That is the most
continue breastfeeding.
But for the mastitis, you need to take something.
Along with whatever we
One
have
is continuation of breastfeeding. Yes. And next,
for mastitis, we require antibiotics as well. And always please remember, antibiotics are broad spectrum antibiotic. Preferably cephalosporins are given, because in the breast tissue, it is along with the cellulitis, it is the component of adenitis. So we need to have broad spectrum antibiotics along with anti-inflammatory and pain killers.
Right.
That is the mainstay, otherwise it will progress to breast abscess.
Breast abscess. So our aim is to give antibiotics, anti-inflammatory, relieve her of her pain, but continue breastfeeding with proper technique so that she doesn't progress to breast abscess, which is this, this is breast abscess. Can somebody talk about the treatment now? I think.
Oh,
Yeah,
okay.
anybody? Last, Dr. Charu Modi.
Yes, ma'am. Ma'am, if the breast abscess is small, we can the age-old theory of
This is
incision
a 6
drainage.
by 6 centimeter abscess. You tell
Okay.
me for this
So,
patient.
ma'am, it can be drained very easily by repeated, suctioning by wide bore gauge needle, around 14 to 16 gauge needle.
Right.
We have to aspirate the pus. We have to aspirate under ultrasound guidance, because
Yes.
every loculi has to be emptied. Otherwise, it will pent up. The secretions will pent up, and again, it will land up in further more damage. So nowadays, under ultrasound guidance, the abscess is drained. It has got various advantages, like there's no separation from of the baby with the mother, no hospitalization, no anesthesia is required, and only this thing like hitch is that repeated aspirations have to be undertaken in order to relieve her of this pus.
Yeah.
And
So
broad
you
spectrum on
talked about the
antibiotics.
treatment of the abscess as such locally, but because it's a abscess, so pus anywhere in the body has to be
Has to
drained,
be
but
drained.
it has to be taken care by
Right.
antibiotics, anti-inflammatory. At
Under
the
cover of
background, you
antibiotics.
need to continue with the antibiotics, anti-inflammatory, and then say if it is a superficial abscess, might as well drain it, it with a whiteboard needle, as you rightly said. And of course, if it is a deep-seated abscess or with multiple loculi, you have to drain it under, confirm it at least it is drained out completely and there are no additional loculi.
Breastfeeding to continue here again.
Breastfeeding has to be continued, because people have lots and lots of myths about this, that if there is pus, you should not feed the baby will have infections and all these things. So first and foremost, it's the localized collection of the pus. It is not in the breast milk. So milk is safe for the baby. Secondly, there are certain antibodies which is in fact coming from the mother and taking care of the baby. So continuation of breastfeeding. I'm sure the obstetricians of my generation, maybe who started working 35 years ago, we have seen patients going forward. The moment the patient used to come, people used to refer to surgeon, and then IND and the whole thing is spoiled, and you have to pack the breast abscess, the cavity daily, and it used to be so messy that we have to sometimes actually suppress the lactation, and that is the worst thing we could see in our tenure. But we have come up with this technique, and we successful. We are very proud to say that we have been doing this over I think since last 15 years almost. We have not done any IND. We have not sent any patient for IND. So the most important message here is continuation of breastfeeding in a proper way, the way it is recommended. Exclusive breastfeeding, antibiotics, anti-inflammatory, hot compresses, cold compresses, continuation of the hygiene, and then of course continuation of the breastfeeding is the way forward. We don't have to stop breastfeeding, because breastfeeding is the best. And as all of us talk about that, it is breastfeeding, in Marathi we say it is the amrit for the baby, because it is everything for the baby. It's a complete feed for the baby. It has got a immune booster qualities. It protects the baby from so many allergic diseases, skin diseases, respiratory diseases. It protects the baby from so many long-term diseases like diabetes, hypertension, and so many types of malignancies as well. It improves the baby's IQ by more than 8 scores. So definitely breastfeeding is the best. I would invite the expert to make few comments, and then we go ahead. Just one comment by Dr. Diva, and then
So, Thank you, Dr. Sneha Bhuyer, ma'am. And I'd just like to add 3 points quickly. In the challenges which a woman faces while breastfeeding, the first challenge I would say is her psychological challenge. And a mother thinks, can I really feed a baby for 6 months exclusively? Will my breast milk be sufficient? To answer this question, the counseling by the obstetrician during antenatal and postpartum period is critical. Number two challenge that a mother faces in India, especially, is the visitors. The first 2 days, rather, the first 1 or 2 hours are so critical, and that is the time when the room is full of visitors and they barely let the mother and the baby be together in a quiet. So she needs shanti, she needs quiet place, and she needs support at that time. And also, the third challenge that she faces is that people come, celebrate, and then they go away. But there is nobody there to do her night shift with her. So there is lack of sleep. When the patient comes back to us after 7 days for a postpartum checkup, many of them come with literally, emotionally and physically drained out. So before we send the mother and the baby back home after delivery, we must tell the relatives and the attendants that they should do shift duty along with the mother. Sometimes they have to even store her milk, breast milk, when she's awake, so that the baby can be fed while the mother sleeps for a little while. So rest, her psychological challenges, and the visitors. No visitors allowed is a very good thing to write in front of her door. So thank you so much. It was an excellent panel, and Dr. Sneha Bhuyer, who better can do the justice to such a thing. Thank you so much, everyone, for having us here.
As we come to the end of this enriching FOGSI ICOG CME, it's my privilege to propose the vote of thanks. First and foremost, I extend my heartfelt gratitude to our FOGSI President, Dr. Bhaskar Pal sir, the Chairperson, Dr. Sheila Mane Madam, our Secretary, Dr. Pratik Tende, for their constant guidance.
सेशन कंक्लूड करके 2 मिनट.
ठीक है मैम. Niba ma'am, you want to say? Ma'am, we can't hear you.
Unmute yourself.
Nibha. Okay. Thank you so much. At the outset of this thank-giving position, I must thank the whole of the ICOG team, Dr. Sheila Mane Madam and Dr. Pratik Tambi sir, for giving us the opportunity, the Breast and Puerperal Health Committee, to do this session with the ICOG. Though it was in a very short notice, but I think I could get the best of speakers, best of moderator, and best of panelists. So thank you, everyone. Thank you, Dr. Mangala Vani, Dr. Shashi Bala Bhosle, and Dr. Lakshmi Shrikande. All were so wonderful. The talks were not to be missed. I think those who did not attend, they were at loss. So I will be sharing the recorded version in the group so that they could get the best of the messages of all the 3 talks: the antenatal care, the first golden hour, the less of milk, and the Dr. Mangla's ever brilliant breast position, and the early initiation and the good latching. It was just wonderful. And I must thank Dr. Sneha Bhuyer, though she was very busy in all the conferences and doing the panel moderation and giving talk. In between, she accepted to moderate this session, and we must do the 3 cheers to her that she did it, and she did it. I think one of the best panel we just heard in a webinar. Physically, we have attended so many, and the expert, Dr. Divya, your concluding remark, good, very brilliant. And Taru, I think she has left. She was also very good at her co-moderating the panel. All the panelists, Dr. Anita, you were the most experienced one amongst
Thank you,
everyone
dear.
also. So thank you, Dr. Anita, Dr. Meeta, Dr. Deepa, and Dr. Charu Modi, as she's always ready to join
Thank
all
you,
the
Nibha. Thank
sessions.
you so much.
And thank you, Charu, Dr. Shilpa, Dr. Lalita. Those
Thank you.
are the lactation specialists of the team. Thank you, everyone, and thank you all the learned chairpersons for sharing your input and giving your valuable time. Dr. Shobha, Dr. Vidya Tovi, madam, thank you so much to be here till the end. Dr. Pragya Mishra Chaudhary, our president, Dr. Supriya, Dr. Amita Sinha, Dr. Rosa, madam, and she was so excited accepting to join this webinar. Thank you so much, madam, for your so much valuable inputs. And our two co-conveners, Dr. Meeta and Dr. Deepa. They came to know that they have to co-moderate this session at the last moment. Thank you so much. You did this so wonderfully without any hassle. And thank you, Nilima, for providing us the beautiful platform. There was no problem right from the beginning and to the end. And thank you all the delegates. There were more than 80 participants. I think sometimes it went to 90 also, and at the end they were showing 72 more. So it shows how brilliant were the speakers, the moderator, and the panelists, and the chairpersons, everyone. I hope that we'll get some more chance from ICOG with the Breast and Puerperal Health Committee, and we'll do more and more and more brilliant sessions. So thank you, everyone, once again.
Hearty congratulations.
Thank you, ma'am.
Thank you.
Congratulations.
Thank you, ma'am. Thank you so much.
It was too good. It was
Shashi.
such a
Well done, well done.